I wanted to go over, let me see if Sandy Schneider is there. Yep. And Sandy, I'll probably pick on you in just a second. Is that just a heads up that next week, I think I may be inviting a few people on that have to do with crisis coping and resilience, and some of the various offerings are out there. Craig, are you there today? Yeah, Craig Manifold. Craig, are you there? Can you hear me? Well, if not, I'll bring him in later. But Craig attended one of these sessions run by a guy who does a thing called Theater of War, which is where they use Greek tragedies to talk about some of the psychological impact of seeing kind of bad things, whether in the military and or in EMS, et cetera. So it's been a very interesting, just another way of looking at things and engaging people. And we'll probably have them on next week. I got to check on it, but I was told that JAMA article about TXA was supposed to come out today. It's constantly getting bumped by COVID papers, so I'll have to look and see if it really is out. Today's issue, I'll know if my mail comes here pretty soon, if it came out or not, but you might be looking for it. And we'll be putting out some information on that later. And if I get more information as we go on. Is John Jew on with us today?
I'm here, Paul. Go ahead.
Okay, good. Hey, just later, if you get a chance, I'd like to see if you can address the issue I brought up about, the obesity, and also some of the other issues that you brought up this week with, regarding immunity in Iceland and all that, if you don't mind. Okay. So,
sure.
Trying to give everybody a little preview as I'm sort of dancing while we're waiting for people to get on. And then, let's see, there's going to be a webinar right at the end of this one, or, it's around 1 o'clock Eastern and about 12 o'clock Central, from the Secretary Treasurer of NAEMSP. He's going to talk about the economic impact of COVID-19, particularly on EMS systems and all that. So that's Jose Cabanas, and he'll probably be, I guess, preparing for that right now. I don't know if he'll get on, but if he does get on, I'll have him give you a preview about what that's about, etc. We also will have on today, from what I understand, we'll see if it works out, the president of the American College of Emergency Physicians, as well as the president of the National Association of EMS Physicians. And if that's not enough, we're even going to have people such as, what's his name? What's that guy's name? Ken Shepke on, I think, too, as well. So anyways, we'll see how that goes. All right. So let's go ahead and Jose, if you don't mind, can you tell us just a little bit about, since I see you're on, you mind giving us a little bit of a preview of what you're going to talk about, which will be right about the time we end up here.
Yes, good morning. Can you?
I can't see you, but I can hear you.
You see me now? Perfect.
Yeah.
All right. Thank you all so much. Yeah, thanks so much for Paul.
Hey,
no, we just
I just want to let you know, when they introduced you today on the Florida call, they left out the important stuff, like how you married up and all that kind of thing. They don't know. It's like too bad they didn't have any of those really important background information, actually, and how you know all the best restaurants in Austin too, as well. So it's great. No, but welcome to our show again, and of course, here's our eagle from Raleigh, meaning the Wake County area. And, Jose, who's the Secretary Treasurer currently of the National Association of EMS Physicians. Take it away, Jose.
Thanks, Paul. No, I just want to put a quick plug in. As you all know, NMSP has been doing our town hall webinar series where we're trying to provide resources for our members and other participants. So today at 1 o'clock Eastern time, if you have time, please join. We're going to have our GFS Wealth Advisors for NMSP engaging in a conversation about the overall impact of COVID-19. What is the current economic outlook? What is the impact of the pandemic? And where things are heading in the upcoming months in early 2021. So I think it's an interesting topic with the still uncertainty in the markets and what's going on with the pandemic. So if you get a chance, please join. It'll be 45, 50 minutes, but it'll be an interesting option for you to ask questions about sort of the overall economics of COVID-19.
All right. Well, thanks a lot. Anybody have any questions for him before we get on to the next level? All right. Let's see. I want to make sure I'm not muted myself. Okay, Sandy, are you going to be able to stay on past 11? Because that's when it looks like we're going to regroup with the presidential suite.
Yes, I will be, and I'm going to let them handle it, and I'll just be in the background.
Okay, sounds good. All right, good, very much. And Deb Pena, are you there today? Hey, Deb, are you there today? Is that you on there? We're just going to make sure.
Oh, yes. Sorry, I had to unmute. Yes, that is me.
Hey, yeah, so what I wanted to do is just make sure when they have the discussion, we're going to talk a little bit about the ketamine issues later, just to make sure you can pipe in and make sure that everybody gets a good briefing on the particular issue regarding the position paper you guys did with the surgeons, okay? If you don't mind.
Yes,
Okay.
I can be here.
Okay, good. All right, just want to make sure. Anybody else that has to get off early before that time or have any kind of problems over the next hour or so in terms of participation? Okay, so let me, go ahead. Did I hear someone? Okay, hearing none. I do want to go to Crawford Meacham because I heard that Uber is now transporting trauma patients. Is that right, Crawford, in Philadelphia?
I don't know.
Peter,
the next presentation.
Yeah, well, I was going to say is after we heard your presentation last week, I guess everybody was anxious to know more about how to do that. And Peter Antevi, you're there, right? Can you tell them a little bit about that? What the story was?
Yeah, no, no, there was an article that came through my email. Somehow it came through that there was a gal who got shot in Philadelphia, and she took Uber, and so I forwarded it to Paul and to Ed because we all gave a talk about, and we were at HHS a few years ago now, talking about tourniquets and stop the bleed and so forth that Paul's been talking about for many, many years. And the one thing we talked about was, hey, shouldn't Uber drivers know how to stop the bleed? But clearly, she kind of handled it herself, but just thought that was a good story.
That is Philadelphia initiative.
Yeah. I know it's really interesting. So I thought it was great that it's been a success so far in 100% of the cases.
Next, I'll be the Uber medical director.
Exactly right. But it's interesting what Peter brings up is actually valid in terms of a couple years ago we were asked to join HHS, the ASPR, Assistant Secretary of Preparedness and Response, their Tracy program, to write up an update on events that happen and what we could do to help with mass casualties better in the future, in terms of triage and various other approaches. And one of the things came up, especially after the Las Vegas incident, in which, Las Vegas Strip incident, I should say, out in Clark County, in which all those people were shot, and a lot of people went to the hospital via Uber. So we said, well, we need to train Uber drivers. So we're making progress there. And Philadelphia is always taking the lead. So they can. Didn't you guys did you guys even write a constitution or something like that for one of the largest nations in the world, right?
Yeah, something like that. Hey, Peter, can you actually send me the email?
Here it is, right? Okay, look at.
Yeah, give them AEDs and Narcan and we're set.
We actually already did.
All right, we got a good quorum going now. Thank you very much for this. It's excellent. All right, so let's move on. Let's see. First of all, let me just take a couple reports real quick from our major cities. And if you don't mind, could you get on Glenn Aceda, just what's the latest in New York? Are you guys still holding tight in terms of your...
Yeah, good morning, everybody. Our volumes, crept up just a little bit last week, at the end of the week, to about 3,700. I thought this Labor Day weekend we're going to get crushed, but actually it's still under 4,000, holding about 3,600. So still 500 to 600 below our 4,200. Our shootings just continue, and like other major cities as well, unfortunately.
Yeah. So let me ask you this: didn't we? I guess I didn't take it. So did a survey go out to you guys, and how are we doing on completions on that? Stein, are you there? Stein Bronsky, you've been collecting data about how many penetrating injuries you've had around the country. in the different cities. How's the compliance so far with the number of surveys completed? Stein, are you there?
Yeah. Can you hear me?
Yes, I can, sir.
Okay. Yep. We are getting people answering the survey. I think we are up to about 23, 24 full responses, and more are coming in. And so we will keep following that and reach out to the people who have not yet given the data to help us out.
Have you taken any quick peeks yet, or is it that's something we still have to wait on? You have any preliminary information for us, do you?
Let me, if you can come back to me a little bit later, I'll take a peek and have better idea for you.
Yeah, I mean, I think we know where we're going, but I'd like to see if it correlates with something or not with the different cities. All right, so let us know. And so thank you very much, and so on. And then I see that we have Sean Coven on from Honolulu, medical director there. And one of the things that Honolulu was just hardly touched, as Libby's been reporting to us over many months, and they basically, their tourism is way down. And so it just was a locked in area. But then it just really took off like wildfire there, COVID invasion over the last month or two. And so I just wanted to know if you don't mind telling us how that's impacting and what's going on there, Sean.
Good morning, all. So we instituted a stay-at-home order.
Yeah.
So we're in the second week of that. Our case counters were spiking up above 200. Yesterday's count was 105, so it's come down significantly.
Okay.
We have had some problems with the EMS system in that several hospitals have been had an uptake in COVID patients. And so we're sort of readjusting the system in order to redistribute ambulance flow, but otherwise we're hanging in there.
Yeah. Is your trauma way down, or is it going up again?
So I think the trauma is about what it normally is, but it is starting to uptake a little bit. And I think the reason why our data might be a little bit differently is because we reinstituted the stay-at-home order. So therefore, there's a little bit less, like, MVCs and gunshots, et cetera, because less people are starting to be out over the last 2 weeks or so.
All right. Thanks very much. Hey, and then I wanted to jump over, if you don't mind, to George Hatch. I just want to bring up an issue real quickly. So George Hatch is our executive director at COAMPS, and the certifying agency for training programs. And George, tell us a little bit about, you guys are struggling with ride-alongs and in clinical time right on the streets. Is that correct on a national level? Is that true or not?
Yeah, Paul, thanks. I think when I joined the call a couple months back, that was sort of an emerging issue that 700 paramedic schools around the United States are dealing with, and that is that the clinical sites have closed for their students, and mostly the capstone experiences where they're doing their ride-alongs to get checked off so that they can take the registry exam and test. Those have kind of dried up unless they were working for a particular service. I was just looking at sort of the survey that Jim had sent out, I guess, to the Eagles earlier in the last several months, and it kind of confirms what we already knew, which was that programs are struggling to get that experience. I think the bigger issue at this point is, when's that going to open up? You've got an educational pipeline that we keep talking about sort of on another call that I'm on, and that's a concern of the schools. It's not just the paramedic programs, but it's the feeder programs, which are the EMT sites that are then feeding over into the paramedic program. So I don't know if you guys are looking at that, but we would certainly like to have some more information about that. Students are getting back slowly, I think, into their campuses, so they're able to do some limited exposures with their laboratory settings. But if states, and in some cases physician medical directors, are not going to allow simulation, and I'm not necessarily telling you I would want that, but where's the where's the sweet spot on that? That's where we're at.
So the issues that come up are several things. The pressures to get them out there are obvious, which are, have they been really adequately trained or as best we can, or are we going to send people less exposed as you hire them, but you may be putting them on a longer probationary period so we can make sure that they're doing okay, or whatever it may be. That may be part of it. And then the other issue is their risk for the school if they send their students out there. Of course, that can be handled with waivers or whatever else, that kind of thing. But ultimately, there are issues that in this pandemic, there is an increasing amount of fatigue, a healthcare provider fatigue all the way around, and maybe people not wanting to go into public safety, or I'm getting out of this, or whatever it may be, because I don't want that risk of exposure, or whatever it is. But if people do get sick or contract it, then you've lost personnel, resources. And so the point is, down the long line, is that we may be losing personnel, we may be short staffed even more so than we are in many areas of the country right now. And so that will be an interesting new trend. Peter Antevi, you run a program, don't you, down in the Fort Lauderdale or Broward County area? Is that right? What were the issues you're facing, and where are you going with that? Are you getting help from the fire departments or not?
Paul, thanks for bringing this up, and George, thanks for coming on.
Yeah, no, I'll mute this for a moment.
I am hearing feedback, so I'm sorry about that. Yeah, so I would say, Paul, and listen, I'm blessed to have you as my mentor down here working with me. But yes, we have two very large programs here. We have hundreds of students on the EMT and the paramedic side, and the hospitals have completely shut down. So we've gone to complete simulation. We have probably the best EMS leadership in the state, I would say, in people like Chief Steve Shaw for Lauderdale, Bill McGrath in North Lauderdale. We've put together documentation to try and get the students back in. However, there's still a little bit of resistance from the fire department side, from the union side, and the big fear here is the anxiety that a student will kind of come into the bubble of the fire department and then will bring in COVID. However, there's about 6 departments that have opened up. We've had no problems with any of those departments. There have been no infections because of students. So I personally feel like, based on our history and our knowledge of COVID, masks and gowning and doing all the right things, then I think it's time for us to get back into this, because myself and Paul, we could pencil whip and get these kids 100% through simulation on mannequins and get these kids out to the real world. But I feel like I'd be doing a disservice to those students. And then it puts the onus on the fire department to then go and extend their probationary period beyond what it is today. So I think now is the time to really reopen the discussion, like George was saying. And so I would love to hear what other people are doing, if other people are doing anything differently than we are, or is everyone just kind of watching and waiting?
Peter, could I add one other thing? I think the other part of this too is that the National Registry, at least in the interim, has created a provisional pathway for students to take the exam. They can take the written exam at a Pearson VUE testing site, but most of the psychomotor exams, which is the other piece of that puts it together, have just simply been shut down. And the ones that are taking place are kind of fewer and farther between. So there's really, some of the states are not recognizing a provisional certification. And therefore, if a fire department or an EMS agency is not recognizing that, the students are really kind of stuck. There's nowhere for them to go.
Yes, I'm glad you brought that up. I've gotten letters from parents on both sides. One is, how could you be putting my kids into the fire? And then I got one from a parent recently saying, how dare you just give my son mannequins for simulation? So we're in a very, very tough spot right now. And I think we have to rise to the occasion here. We're all educators. We've all been there. I think we really have to make a move. We have to make it soon.
Now, on a global level, one could argue it's part of the job, and that's part of what you learn while you're doing your clinicals. And we really need to be protecting people regardless whether they are, from another, but, like there'll be always an anecdote where someone picked up somewhere and then brought it into the fire station as well. And so that's always kind of an issue that comes up. All right. So I'm trying to think if there was anything else I wanted to go to before we get into our meetings. Hey, John.
Manifold, if I could join in or ask George Hatch a quick question on this.
Yes.
George, there are no states that are mandating non-in-person training and education. Is that right? I mean, because I think it's really programs and healthcare systems that have put the limitations on our students. Really, it's right. It's not any state mandated process.
I think from what I know, Craig, I think most of the states have said that they're not going to prohibit things, but I think what they've done is sort of shifted the burden to the program's physician medical director, to the school itself, and to the state office of EMS in that state. I mean, that's really the four entities that it kind of comes down to.
Right, and what I've observed from education programs, and this is a generalization for sure, we know there are exceptions, but many people want to join the bandwagon and say that there are issues. There are a few people like Peter and others who have been proactive in that, right? Because our environment that we're putting our students in are exactly the same environments that they're going to be training in. And I think we have to do a better job of educating and pressuring our healthcare institutions and our agencies to be able to do that. There may be some help if there's some guidance or some other pieces of information from the national organization to help push that. This may be a good time for that, but I also haven't seen that out there yet. In other words, these are the conditions that you should be doing the training, and obviously students bring their own PPE, but they're going to be operating in that environment, and we just need to make it a reasonable approach in their training. And so I think we have to work a little harder at that at the institutional level.
Okay, and then for those of you who are not aware of ZIP, Craig Manifold is the National Medical Director of the National Association of EMTs, Emergency Medical Technicians, and so has a great handle on a lot of this, so appreciate that. Craig is also in part of the team that hosts this with Julian Maldonado from District 7 down there in South Texas in the San Antonio area that put on this Zoom. So we want to always thank them and their chief for making this asset available, invaluable asset available to us all. So thank you so much once again, Craig. So, hey, Craig, just briefly before we move on, since I have you there, can you tell me briefly that you did witness the theater of war thing? I'm going to try to have the guy who runs that, that DOD project on with us next Tuesday. So I was wondering to know if you could give us a little bit of background for those who are on now.
Oh, yeah, it was a great opportunity for those people who enjoy the arts and humanities. Again, with professional actors and folks from the streets in the first responder world of paramedics, EMTs, and military responders in different venues. And it really goes back through, I'm going to show some of my ignorance, Paul, so feel free to correct me, but again, through some of the Greek tragedies and other plays out there, but trying to bring those, a few of those scenes into the modern world and the complexities that are occurring and the issues that our folks on the street are actually experiencing and some of the conflicts that are out there. And I thought it was really a nice way to demonstrate and share with people through acting and the play on screen, if you will, and an ability to just look at another lens to look at these issues. It's probably not for everybody, but for a lot of folks, I think they may appreciate the artistic value with that. But really, getting into some of the underlying complexities of managing these things that people are seeing with the COVID pandemic and some of the fatigue issues, some of the other conflicts that are out there that we have to address and things. So yeah. I found it very personally enjoyable. It'd be great to have the folks on board for a little while. So. Exactly.
Well, I should mention along those lines that Hillary Gates and EMS World is featuring in October, I think a 2 or 3 parter on issues of crisis coping and resilience in EMS and some of the problems. And the part 1 is talking about that it's out there and that we need to be discussing this. We need to be taking action on it. And so I think in part 2, we're going to give some of the specific areas that people have done from a very basic level, like just having Friday evening meetings on Zoom or whatever it may be, social closeting, right on up to the sophisticated levels like using these high-level arts and all the movie stars that they're involved in that particular event. So that'll be kind of cool. So we'll have more information. He's one of the people who'll be contributing to that, along with Chris Colwell, and I think and Lauren Maloney and Sandy Schneider, et cetera. A lot of people that are just joining in to make it better, and Peter Antevi for that whole series that are coming out. Okay, so now let's go ahead. I was figuring this might be a good time to introduce some of our guests that we're having here today. Anybody else have any other comments before I move on to the meeting with ASAP and NAMSP? One thing I did see on the various things that are being sent up to me, that the EMT enrollments are going way up. Both I think I saw in San Jose, Chuck Burnell with Acadian throughout New Orleans, throughout Louisiana and Texas, etc. And anybody else have increases like that? And how do you explain that? So Mark, what do you think? What's going on there with your increases out in San Jose with the increases of EMTs getting, applying for your campus programs?
Yeah, so I actually have a meeting with the chief instructor later today to talk about budgeting for this. But it just sounds like that a lot more people here are very, very aware of the need for healthcare services in the future. These are undergraduate students in our program. And so most of them have just kind of expressed they want to know something about healthcare so that they can be of help when the situation arises.
Yeah. Okay.
Kind of an altruistic student-based thing.
And Chuck, how about on your end? What do you think's going on there?
Paul, I'm not sure it's not the post-911 syndrome, with everybody.
Yeah.
I think that's a lot. I've asked a lot of the students because we've, our EMT program, we had over almost 400 sign up. That's across 9 sites, but that's a lot of students when we normally take in 220. So we've had challenges just accommodating them. In the clinical experience that George alluded to earlier, we've had, to overcome a lot of that stuff too. We're doing a heck of a lot of simulation stuff, but it does not replace the stuff on the truck,
Yeah. Okay, got it. All right, and I see there's a lot of chats that you guys could talk about resident rotations out in EMS later, but I'm going to move on to what we have to do today. Chris Colwell, you're going to have to get off here pretty soon. So I just thought I'd bring you in from San Francisco. Any comments to make before we get into this? And we are going to be talking a little bit about ketamine, number one, but anything else you have to add to the current situation?
Thanks, Paul. I think everybody knows how I feel about ketamine, so I'm very much looking forward to the discussion, and hopefully I can stay on long enough to hear the gist of it. No, in San Francisco, we're seeing the same thing. We're seeing increases in applications for EMT and paramedics. We've now reached basically back to 100% of our EMS volume. And our second surge that we had here in California seems to be down somewhat. We're now down to about 15 in the hospital and only 2 in the ICU. And again, transports are about where they were pre-COVID. So we're kind of sitting in steady state waiting for that our next surge.
All right, thanks a lot. All right, so with that, I will turn it over to Sandy Schneider, if you don't mind, Dr. Schneider, who's our Associate Executive Director over at the American College of Emergency Physicians, that do the introductions of our 2 of our special guests here today. And with that, I also want to mention to Mike Levy that make sure you pipe in whenever you can as the president-elect of National Association of EMS Physicians and one of our Eagles from Anchorage. Okay, so Sandy, if you don't mind, tell us who we're going to have on with us. I think Bill and David are both here.
Yep, I had to unmute. I'm sorry. It took me a second.
I know, that's why I always have a little filler to give you time, so it's fine.
Thank you. Yeah, you think I'd get used to it by now.
Yeah.
So as you know, we had this discussion last week on ketamine and the 2 organizations. I thought it'd be best to hear from their presidents. So it gives me a great delight to introduce to you people you probably already know, David Tan, who is the president of NAMSP, and Bill Jaquist, who is the president of ASAP. And I'm not sure which one of you wants to go first, but maybe Bill, because we sort of started this, and then David, you can talk a little bit about NAMSP and about the conversations that you guys have had together. I'm going to turn it over to you, Bill.
Sure, and I'll certainly leave some time for questions. I'm sure there will be questions. But Just, I think to maybe give some context to the joint statement, where it came from, how we came down to the statement we came to. And I think many of you, or if not all of you, are pretty well aware of some of this, if not most of it. But the biggest issue, I think, was when ASA put out their initial statement on essentially on the use of ketamine and how care was delivered in the pre-hospital area. And that rose to our leadership surface pretty quickly. And the issue obviously was we wanted to make sure that there was something that would counteract that particular statement very quickly. Recognizing two things, recognizing that the real people who provide and oversee pre-hospital care are not anesthesiologists. They are primarily emergency physicians, among others, but primarily including, obviously, the groups on this call. And the second was the long struggle we have certainly had with the use of ketamine, the appropriate use of ketamine in many settings, including in hospital and pre-hospital. And so trying to counteract that statement pretty quickly. Fortunately, for the most part over the years, at least at a leadership level, we have had a pretty good working relationship on many things with ASA, not everything. Primarily, I think, related to surprise medical billing and our unique and common circumstances related to that. So we got on the phone with them and worked through sort of our problems with their statements and had a long discussion on the pre-hospital arena, who was providing care in that area, what our role was as emergency physicians and our specialty societies. And there's a lot of education there, frankly, for many people in anesthesia that don't really understand or have the context of what happens, and even who and what roles people play and their roles from EMT to paramedic and on up, and their capabilities. And so I thought it was initially a good call, but that call led to a good discussion on creating a joint statement, which we did create. On that initial call, Dr. Myers was on that initial call, and through some of that initial thread of discussion on the joint statement, so he was able to, so he's on the call, but I won't speak for him, but he was able to provide some very good context that we would not have had without him on the call for that. So I appreciate his being on those initial calls. Subsequent to that, I went back to their boards and they wanted to make some changes to it. Their reason for getting on the call primarily from their point of view was concern about some of what they perceived to be quality issues, and particularly from Colorado was their point of reference at that point. So from their context, they were dealing with this on a quality issue, and clearly from what we got on that call and for the next long thread of discussion was they were very concerned about how law enforcement integrated into the medical community in these circumstances and what their role was and how they got to it. Along the same time as well, 60 Minutes picks this up, and probably through that next week or so, not only was 60 Minutes sort of working on their potential presentation with anesthesia, but because of the conversation we had in our work by our staff, I was able to speak with their associate directors probably for at least an hour overall and 3 or 4 calls to talk about ketamine use, the pre-hospital arena, excited delirium, multiple other topics related to this, including obviously the concern of its misuse in certain circumstances. So we did ended up with a joint statement. At one point we did say it didn't meet our needs and did walk away, but after conversation with their president, we did come back with ASA and create the statement that you saw. And so that's essentially what's been happening in the last week or two, which, well, I don't even know, it's COVID time, whatever that was, since we started and since it's continued. It's been pretty much the context, at least from our perspective. I think two things on the top of all this that we wanted to make sure. Got out there in opposition to the initial statement from the ASA. The first is who has, especially as physicians, who has the best and most experience in the pre-hospital area? And also, what is the context in which we use ketamine that helps people understand why it's the choice we come to? And what wasn't coming out, I think, to 60 Minutes in many ways was the morbidity and mortality associated with many of these conditions that left untreated could have significant outcomes. It was merely a context which says, well, we have this amount of information and it seems bad. Trying to expand that context to, well, you have to understand what would be happening if there weren't this option for treatment and if there weren't these well-trained people both overseeing and providing emergency care in the communities. So I'll stop there, and that's kind of what I'll start with, and obviously I'd like to hear Dr. Tan and then some questions.
Yeah, thank you very much, Dr. Jacquez. Appreciate you telling us that. And then David, can we now pivot over to you?
Sure. Just thank you, Dr. Pepe, for the invitation to appear, and of course to Dr. Schneider for the kind introduction. As you know, as Dr. Jacquez alluded to, when the American Society of Anesthesiologists first released their initial statement in July, we were also fairly shocked, as I think all of you can agree that their original statement was really full of a lot of misleading and I think in some inflammatory statements, to be honest with you. And so I do want to take a moment to thank Dr. Jacquez and ACEP for helping to steer that statement around from basically saying that ketamine should never be used in the field, it's incredibly dangerous, to at least saying that, well, maybe it can be used in the field, but with medical oversight. So clearly a lot of work on the part of ACEP to help correct that, or at least soften their statement with the August statement that they released about pre-hospital use of ketamine. I think certainly from NAEMSP standpoint, and I think certainly from this audience, and speaking off the record to who I consider to be an audience of peers and colleagues, I think we can agree that anesthesiologists probably shouldn't be commenting at all, frankly, on the pre-hospital management of really anything. And I think they mean well, but I think that they're way out of their lane in this area. And just so that you know, I had a very collegial conversation with the president of the American Society of Anesthesiologists. And at the end of our conversation, I did have her concede that the physicians that are probably most appropriate to comment on the management of any pre-hospital emergency is an EMS board physician, and or at least a physician that specializes in that area. She did agree with that, but she was quick to add that that does not or should not, in her opinion, prevent anesthesiologists from commenting on EMS medicine. And very politely, I kind of wanted to ask her why she thought that. And the reasons she gave were interesting. She said basically that she feels like anesthesiologists have a very long track record. She feels longer than surgery or medicine, frankly. She said that anesthesiologists have a very long track record of being the champions of quality patient care. And so culturally, they feel like they are entitled to comment on quality patient care. Secondly, she stated that ketamine is an anesthetic. And as an anesthesiologist, they should have the right to comment on anesthetics. Now, there are all kinds of reasons why that is kind of a weird argument. We certainly don't ask cardiologists permission to use diltiazem on the ambulance. But be that as it may, it was clear that we were not going to convince her that veering into our lane was inappropriate. But at least at the end of our conversation, and again, very collegially, the ASA agreed that for future reference, if they're going to opine on the management of pre-hospital emergencies, that they would at least involve EMS physicians. So that was very welcomed, I think. So I think as EMS physicians, we need to be highly aware of their philosophy as far as ASA goes on their role in commenting on our practice of medicine. Having said that, we also have to be sure that we as EMS medical directors are incredibly engaged with our systems, our local governments, and we cannot let incidents get out of hand. And we need to make sure that our own house is in order as far as making sure that not only ketamine, but other low risk, high frequency events are closely monitored. And this is something I think that would be an important talking point if you were to speak with the media on this. And I think and Dr. Jacobs and I also had a very, very good talk recently, and he very deftly handled the media inquiries about that as well. And I think if we keep the focus not on a singular act like the use of ketamine, but always come back to our role as patient advocates and the quarterbacks of our EMS system, that patient safety is the goal. Ketamine, therefore, is no different than other low frequency, high risk events in the back of an ambulance, like delivering a baby or doing a surgical crike or anything else. And I think if we keep the message, that's our role as EMS physicians, I think we can keep the conversation patient-centered and try to avoid the political morass that it was rapidly becoming. So, again, I thank you for the opportunity to contribute to the conversation, and happy to take any questions as well.
Paul, I have a question, if that's okay.
No. Go ahead, Peter. Peter Antebi from Florida, from Gabemda. Yes, go ahead, Peter.
So the taser took this hit years ago, and I'm wondering, what did they do to get over this hump that we now find ourselves in? How did they get past the tasers kill people? Maybe we can learn from that struggle.
Well, that's a really good question. And I think what we are doing, we have done, and I think what Taser did was also come back with a lot of evidence. When you make blanket statements like paramedics are out there darting people with ketamine so they can go to jail, and you come back with hard facts and data, that's what drives it back. And that's the only way you can drive it back. And I think Dr. Myers was part of an initial conversation early on in the process where he basically allowed the anesthesiologist to walk the plank, so to speak, and then he decided to introduce some actual data, which was incredibly helpful to show with 14,000 pre-hospital deployments of ketamine that in fact 99.5% of them went to the hospital, not to jail, and that 89% of the time it was used for airway management and pain control, not for psychiatric reasons. And suddenly that person got quiet, because when you come back with data, you really rule the conversation. And so Peter, in answer to your very good question, I think that's what we do. We better know our own systems pretty dang well. You better know in your own system, how many times have you deployed ketamine and for what, and what was their disposition? And
if I could, yeah.
So I believe the ESO data also showed, was able to follow them to discharge or admission, which is also really helpful.
If I could add to that, that is absolutely, it was going to be one of my asks of you. A lot of the data is buried in your, not even in your literature. It's just buried in your entities, whichever the entities that you are. Publish it, publish more of it. We really, you know, we're doing, this is related, but not the entire topic, obviously, but we now have started up another group on excited delirium. And as part of that, we have done literature searches, and there's just not a lot out there. So publish more of your data, because that obviously could counteract, as Dr. Tan said very well, these conversations when you're talking about thousands and thousands of whatever they are, thousands of evidence-based looks at these with outcomes, with use that you all have. We really need to see that somewhere in the literature that more people could access, or that we can access without, you know, even to try to, for instance, get back to some of these conversations that I was having with 60 Minutes, where I would get something from the good Dr. Schneider. It wasn't something that I could point them to in terms of a published article. It was more the collection of data that came from, for instance, Dr. Myers. And so if they had been able, or we had been able to get to that a little more quickly, which I know you will do in the future, then this would counteract a lot of this argument. As one piece of this, there was somebody who gave us, and I don't remember, Sandy, where that was from, but prior there, from their data, the incidence of intubation prior to the use of ketamine with this type of excited delirium type patients was 60%. But anesthesia is looking at this as 40% as being a failure. So the argument against that is, well, it was more before we started using it, because these are highly difficult patients with a high morbidity and mortality, as I've said, that need a quick interaction. And yeah, a lot of them are going to get intubated, but given the right circumstances, the right assessment, it's going to happen with the right people on scene. There's better outcomes. We just don't have enough of that that's published. So keep doing that, please.
So let me, this is Paul Pepe, let me pipe in before I go over to Deb Prina. So a couple things that, in my perspective, we've had a lot of good safety data that's been presented to us here in the past. Like, for example, a 5-year study of 3,000 uses of ketamine in the whole country of New Zealand, where they really had 0 problems. A third of those, about 1,000, were for behavioral emergencies. So there is a lot of information, and we see it all the time. I think what happened here is that there was an individual case, to a large extent, and it may be more prevalent than we think, but it may be that what your point is that it has not been well supervised in some of those systems, and that's the thing. Going back to Peter's point about the taser, I actually did a study on that and looked at, you know, hundreds of uses. If we followed the protocol, there wasn't any problem whatsoever. And in fact, I make the argument, which you guys have alluded to, that if we didn't have this around, the patient we wouldn't be able to control the patient. We wouldn't have been able to take care of them. It's just the opposite. We have an ethical obligation to provide it for them so that we can take care of them medically. And instead of being on the defensive about whether ketamine was good or bad, part of the intention is also saying we have a duty to act here. And so I think that's a couple of important points to make. And I've heard you say that here today. So thank you so much for all this. Deb Prina, can you just so everybody has information, tell us where you are working with other organizations besides ASA?
Thanks, Paul. Well, I think most everyone on this call saw the paper the joint paper that came out as a consensus statement from NAMSP, ACEP, ACS, and several other organizations, NASEMSO. And the reason that paper took 2 years to get to consensus, but the reason ketamine was chosen was the fact that it actually was interesting to hear that conversation. It occurred at an ACS meeting, and it it was, I'm laughing because I couldn't believe I was hearing my ears at the time, but there were trauma surgeons that were going, why are we not using ketamine more? You know, why is it not being used in the EDs, and why is it not being used in the EMS world where it would be helpful? And, you know, I spoke up and said, well, it kind of is. I mean, we tend to use it. I've used it for years in the pre-hospital setting. And the issue came back from some of the trauma surgeons is, well, I've been talking to my EMS medical directors and they won't use it. They think it's Satan, which I thought was a very fascinating conversation. And as we know, we all have different practice settings, but it seemed odd to me that there were medical directors out there that did not like it, would not use it, and were resistant to it. And so with that discussion, it was like, look, this is the perfect topic for a consensus statement. And when everybody agreed to do that, we initially had a fairly broad statement, and then we ratcheted it back to the fact that really this organization and this statement really deals with trauma. And so while the statement I would like to think is a good one, and I appreciate any feedback anybody wants to give me, it probably didn't go far enough for the issues that we're talking about right now, but we felt we needed to focus solely on trauma since we were really talking about that piece. I will also tell you in reviewing the literature, the largest database for ketamine use for any modality, pain, sedation, and excited delirium, belongs to the Joint Command in the military.
Yeah.
It's quite robust. And in all the times that they have used it, in the dosaging that they are using it, which is what was recommended in our consensus paper, they had 0 negative outcomes. They had 0 unplanned intubations. And as such, it's a very safe drug. And I know I'm preaching to the choir here because we all agree on that point. And I think the problem exists with improper oversight, shall I say, and perhaps lack of a strong QI loop that needs to be in place if you are going to use it. And I'll just stop there and let people throw things at me.
Yeah, just some of the B-roll I saw, and again, I'm not doing the investigation. This is all, you know, conjecture, but it looked like some of the B-roll I saw was the paramedic on the scene at the time said, well, we don't need to take him to the hospital. He's fine. And then later the police said, well, what do we do about him? And then can you give him some ketamine? And so it's almost like the police were managing the care instead of us, et cetera, meaning EMS. And so, and then it happened. The other thing is that is the dosage of the drug just didn't seem to be well managed or under control. I think Remley Crowe, for example, just looked at that and through ESO and really showed that there is some kind of correlation with the dosing that goes on here. And so what we've seen and what we heard reported on our earlier calls is that that's part of it. So there just may not be that same level of control. I mean, and then you go into things like where Ken Shepke here did this for status epilepticus and watched very carefully for any kind of signs of hypoxemic problems, and they really had actually nothing significant or not anything that couldn't be controlled easily and reversed easily. And more importantly, some of the hypoxemia was there before they gave the drug because the patient was at status epilepticus. So that's another good point, that there's so many things, whether it's pain, status epilepticus, or the other things, or trauma care that in airway management that we would really need this for, or else we'd be doing disservice for the patient. So. Let me see, Brent, do you want to talk about this at all yourself? Give a reaction since you've been in the mainstream of this. Brent Myers.
Oh yeah, thanks, Paul. Just a couple of quick comments. I appreciate the need to get these published as opposed to simply in presentation form. Those abstracts, for those that are NMSP followers, they're due tonight at midnight. So in classic fashion, we will submit them sometime before midnight tonight. But there are two focused on ketamine. One is all administrations of ketamine over a calendar year. The other is to compare that to benzodiazepines and antipsychotics. And those will both be going in later today. And then we're coming as fast as we can behind that with manuscripts, but there'll at least be abstracts that we can reference in the very near future. So we're happy to progress with that. Thanks, Paul.
Yeah.
Paul?
Yes, go ahead. Yes. Who's that?
Yeah, it's Peter. I want to push back a little bit on the dose, only because, you know, in pediatrics, we've been using ketamine for, you know, over 20 years. And I can tell you that there's case reports of 100-fold overdoses in children, 10-fold overdoses in children that have that cause no harm. Although in the older population, we know ketamine can have some, you know, cardiotoxic effects if you have a patient who's hypertensive already or tachycardic. And so, you know, I'm wondering if someone got 500 instead of 350, is that really what pushed them over the edge? Or is it simply that they just had badness going on and they were being choked and hogtied? Maybe that was the problem. So I don't want to anchor on the dose per se just yet.
No, I'm just saying it's a variable we need to be addressing and looking at, and it has to be part of our medical quality assurance.
Yes, I agree.
And then the other thing is that, as Ken showed in the 1C with the status and various others, there are underlying problems, like you said, that are going to kill these people. One person that died, getting back to your question, maybe. Hey, Rob Holman, Rob Holman, you're live. I've been trying to tell you that.
Hi. Yeah, I'm here.
Yeah,
Sorry.
You're live. We've been hearing you the whole time during this whole thing. You got to mute it, so if you don't mind, okay? So, all right. So thanks, if you don't mind. So, so anyways, where was I? Oh yeah. So anyways, like on the teaser thing, there was one guy that died, but his temperature was 106 when he got to the hospital, and he was in DIC, and he was going to die anyways. But one could argue that the earlier we got to him, the better off he would have been if he was going to have any chance whatsoever. And I think that goes here too. So it's multifactorial. It's not that something's good or bad. It's multifactorial, and it really comes down to the oversight of medical directors, and that's all what we're all about here, isn't it? So, which is really good. Anybody else have any other comments they want to pipe in about this?
Yeah, this is Sandy, and along with the information we have around ketamine now and its use and its safety, there really is a dearth of information around excited delirium untreated.
Yes.
Some people clearly have this again in their coffers, and a good paper describing that this is actually a serious and potentially fatal disorder is really needed. And again, I would really ask that people think about that. There is some, but you know, you guys gave me some great information as we were leading up to the 60-minute interview, but it wasn't published. So anybody can publish that. It would just be really great.
Hey, and then I want to not leave out Mike Levy from Anchorage, our Anchorage Eagle, and incoming president-elect of NEMSP. Mike?
Great conversation. I really appreciate Sandy setting this up just so we could look at the various aspects of this kind of complicated situation. I really appreciate the input from Dr. Jackwis and Dr. Tan. I think that just showed the strength of both organizations and the fact that we're all kind of trying to pull this thing in the same direction from a little bit different angles. So thanks for everybody for that. Much appreciated.
Okay, good. Well, I just want to make sure that we addressed it. So, by the way, both Dr. Jackwis and Dr. Tan, of course, you guys are all just so welcome to be here with us today and stay on the line and all that. We're going to delve into a couple other areas that might be of interest to you. But so, if you don't mind, any other parting words from you before I move on to the next section?
Just thank you for having me. I appreciate it greatly. It's good to hear this discussion as well from that perspective. And again, I appreciate Dr. Myers chipping in on the beginning. Don't blame him for what happened after he left. Certainly that was a decision at the ACEP level. But I hope, as others have said, you understand that at the front of this, as I've said before, that certainly we want to emphasize the incredible role that our pre-hospital people play. Including our EMS physicians, and the need for them to be able to use every tool they have in their armamentarium. So thank you again for having me.
Yeah, good. Okay, so I just was let's move on to the next thing. I just want to quickly, we'll give a follow up, and next week I will probably have the people from the TCCC, you know, the trauma combat, the combat casualty folks from the Army, talk about how they're changing their practice, and part of that's based on the article that came out an hour ago in the issue of JAMA, in which they looked at the ROC study, the resuscitation outcome study on TXA in head injury. And so that paper has just come out. And what's really interesting about it is that overall, because of the way the statistics were done or how they examined it, it didn't look like there was significant, just a trend towards differences at 6 months out, but it has to do with how they lump patients together. But if you look at the group that really had a head injury with bleed, there was quite a significant decrease in mortality in that subgroup of patients. And so it's going to be interesting. I think it will change our practice. And the important thing was that 2 grams up front alone, and not with that trailer of 1 gram over the next 8 hours or so, was where the difference was made. And in fact, if you gave the 1 gram and then 1 gram infusion over 8 hours, that was the same as the placebo group in that particular subgroup of patients with intracranial bleeds. So I think it's going to be a game changer. So I want you all to be looking for it. As you know, we already had this presentation from the principal investigator about a month or 2 ago. And now it's out and we can publicly talk about it. And we'll be publishing a paper on this in October as well, discussing what came out here. So just wanted to make sure you're aware of it and you can look for it. I'll try to have a copy of it sent around to everybody today. John Jew, talking about publications came out. Can you give us a little insights to what happened in Iceland? They were really good about trying to test everybody in the country, especially since they like bars a lot.
Yeah, Paul, I think the real issue there, this is a New England Journal article, I think came out a week or 2 ago, and where the usual Icelandic thoroughness, I'm saying that as a compliment, really, it was really our best study to date on the longevity of antibodies against SARS-CoV-2. It actually showed about 3 or 4 different things. The first thing was that the utility of antibody in a population setting basically yielded 40% more than a PCR setting. So number one, if you want to see the seroprevalence in your population, you need to use a combination of PCR as well as antibody here. So I want to step back a little bit. What they actually did was they studied about 1,000 individuals who they quarantined in and basically got antibody and PCR testing on all of them. And they followed them all the way through for up to 4 months. The second one is that the antibody basically lasted 4 months, which was basically unusual. And it's the first study that actually establishes that as well. The third, if you had to read the details, they used 3 assays, one Roche assay and another 2 assays, I think, which are European based as well. And they actually found a combination IgG, IgM. But the bottom line is that the assay that's probably protective lasts for 4 months as well. And that's the assay against the RDB portion of the spike protein here as well. So that's the third final conclusion here as well. What we don't know from them is the people that were infected and were antibody negative, and there's a certain component of that as well. But I think it really adds to our knowledge, and this is the first study that looks at the longevity of SARS-CoV-2.
Yeah, so thanks. And for those of you who may not know, and I think there might be someone in some country over in Central Asia that doesn't know John Jew. John is our medical director from Portland in Multnomah County there in Oregon, and also our medical director for the Oregon State Police. But John's our in-house expert on infectious disease. He's board certified in the area, and we're always counting on him to. Between him and Ken Shepke, actually, I'm kind of pissed off at them because they just make the rest of us look so bad. They're so bright. So thank you so much again for your great work there. Hey, John, Iceland's done some really cool things. Even early on, they were the first ones to alert us that more than half the people who had tested positive were asymptomatic in their country anyways, and that thing. And so they've been doing really good work in this all along, right?
Yeah, the Icelandic, like most of the Nordic countries, are thoroughly, very thorough, and they have a population that basically probably trusts the government here as well. I'm saying that a little bit tongue in cheek, but they have some assets that we don't have as well.
Yeah. Did they block travel in and out, all that?
Yes,
Early on?
yes, they did. They were early, and they basically it was on their radar. It helps to be an island like New Zealand, Australia, and Iceland. So
And I
it
just
does
got
help.
I just got off the phone with the medical director for Auckland and the rest of the country, by the way. And yeah, they just never got hit. They never had any of the problems we've had, like like the cardiac arrest and so on. And so it's very, very, very interesting to see how they were able to contain that. One other thing though is, speaking of not containing things, that it looks like we're having a flip back in Europe. And so it's just skyrocketing again in France. It's going up in Spain. Have you been keeping track of, John, on that? And tell us why you think that's happening. Is it because they let up the restrictions?
Precisely. I think there's two things that are happening. One of them is that people basically got COVID-19 fatigue and stopped social distancing. The second thing is that they were lulled into a sense of basically it's all over with here as well. So this is mainly psychology. The virus hasn't changed as well. And just repeat, it's going to infect you if you're not infected here as well. Spain actually is the worst, I think. I looked at it yesterday, and they're back on that troublesome track here as well. What I'm trying to say here, the reason that you're bringing this up, is that this could happen to us after Labor Day as well. In other words, we saw our numbers going down, but we could see the same thing in October, November.
Okay. So a quick question I have then along those lines is that there are also others that are thinking that things are going to get worse like later on in the fall as well. So it's all a very confusing thing. I think Mike Osterholm said it nicely to us last week, that this is just embers that are just going to flare up wherever it can over the next little while, and there's no real, and it's like we are no longer in the second inning. It's
like a wildland fire just in California. Just look at California.
Yeah, unbelievable. How are you guys doing up there, by the way, in terms of the the social unrest? Has it affected the EMS system much at all?
Yeah, we're getting tired as well, especially police and fire, because honestly, we were doing okay when the protests were there, but when we have the right wing and the left wing mixed together, you have basically a lot of trauma here as well. They don't mix.
Yeah. So it's not like, it's more like oil and water, not oil and vinegar. So, okay, so let's move on. Well, listen, let's see if there's other people I wanted to get on. I think it's probably time for a good report then from Jim Augustine. If Jim, you can help us out. Jim usually has talked to the International Association of Firefighters, International Association of Fire Chiefs. Any new perspectives there or things we need to bring to the table?
Yeah, thanks. Boy, what a great discussion today. And thanks to our partners across the different organizations and for bringing them together. This morning's IFF-IFC call, IFF is very interested in prevention over this fall, and they've come up with a 4-point presentation to their members. All of you should hear about. The 4 points are: mask up, the same way as you would going into a fire. Check each other, check yourself, take your temperatures. So that you're preventing the disease from coming into the station. Decontaminate yourself, which is washing your hands and keeping your hands away from your face, and apply appropriate social distancing in the public. So the IFF 4 points, they'll probably develop into an educational program for their members. Second, there was agreement between IFF, IFC that vaccines are not a political issue and shouldn't be. And no matter who was in the president's office right now, the attempt would be to move to a vaccine as rapidly as possible because that offers us the best opportunity to return to normal operations and normal society. And that politicization of the vaccine issue is extraordinarily dangerous. And then like you just said, Paul, really appropriate that we're discussing presentations of respiratory illnesses moving into the fall. How are we going to do our record keeping related to it? How are we going to stay safe? How are we going to educate our public? So those were the big issues. Thank you.
All right. Hey, so thank you, Jim, and again, thank you for everything you do. We can't thank you enough. You're the best, etc. Hey, how are we doing now? We added a couple extra cities in the interim, right? How about number of people that we look at as in terms of residential population?
Yes, it's so I just updated all of our membership as of yesterday, and you guys should be congratulated. This organization now represents 185,000 providers and 132 million population, not including people like Ed Rock and what GMR represents.
Or Chuck with Acadian, who's got another 10 million probably.
Chuck with Acadian, yeah. So they're those big organizations are not even included in here. Yeah. And your influence on what goes on in our communities is fabulous. Thanks everybody who responded to the burn dressing issue as well. We got a bunch of responses into that, Paul, and found that commercial products no advantage as yet in our world over cool water, saline, sterile dressings.
So the other thing, I was putting together the paper now for the cardiac arrest. I'm getting ready to submit it. And I was looking at the numbers that we were representing, and there was something in terms of base populations of the 50 largest cities that we were looking at. It was somewhere in the ballpark of 63 million or something like that. But when you include the daily commutes into those cities, visitors, et cetera, that are there daily, et cetera, because these are the large cities where people go, whether it's San Francisco or New York or whatever, Washington, that those numbers go up significantly more. So it's pretty extensive. So, and again, I don't look at that as bragging as much as that we have a lot of responsibility. We have a large part of the population we have to take care of, and that's why I'm so glad we're sitting here talking to each other, helping each other out. So, yeah. And I want to make it clear, the reason why I was really happy to bring on the two organizational presidents, because we all pretty much, most of us belong to both those organizations. I don't like to think of us being separate. We are part, that's part of, what we do. And they're part of our, we're part of that. And I think they're the ones that should be doing the position papers, all those kinds of things. And we want to be a resource because we're part of those organizations. We just have a special niche. That's it. We're just that's like I said, we are just who we are. That's simple as that. Okay.
And, hey, your leadership allows us to do that, and bringing all these talented people together. Thanks to all of you. You all do a fabulous job, Paul. You do a great job bringing us together. Really appreciate it.
Good. Well, it's like I said, it's from the beginning. This is not social distancing; it's social closening here by doing this. It's been nice. So thank you so much. It's been a treat. Let's just move along. Ken Shepke, I did ask you something earlier today. About the issue about the big thing that everybody's coming up with that's been sort of published recently, and every newspaper is about obesity being the single most number one association with getting sick from COVID and all that. So is it just a surrogate variable for hypertension? Is it a surrogate variable for diabetes and whatever? What's your reaction to that? I mean, we don't know the real answer, but you're just the brainiac here. So what do you think?
Well, I don't know if I can give you proof from one or the other. I can give you theories. And if you remember, Dr. Osterholm predicted America would do worse because of the obesity in America. And sure enough, he was correct as usual. So that guy's brilliant. We know that the virus enters the cells through the ACE2 receptors. And of course, John Jew pointed that out. We were doing a little email exchange before, and I took a moment to look up. And sure enough, we do believe that if you have a high body mass index, that's just fertile ground for the virus to replicate. So you probably get higher viral loads as one thing. We also know that just having obesity gives you a low-level chronic inflammatory process, as the adipose tissue is a source of various inflammatory mediators such as IL-6. We all know that, the IL-6 role in severe COVID disease. So just the fact that you have a high body mass index already puts you on the spectrum of towards pro-inflammation. And then, of course, is it just the obesity? It could be just obesity based on those two factors I just mentioned, more viral load and more inflammatory mediators. But obesity is already associated with two other risk factors, high blood pressure and diabetes. And then if you add on top of that the physical weight that the obesity does in terms of causing a restrictive lung disease in folks with severe obesity, and what we're seeing is there's a correlation. The more obese you are, the more likely you have a bad outcome. So there's a relationship there that it does get worse and worse as the obesity gets worse and worse. So I think it's more than a single factor. It's multiple factors all pointing in the wrong direction that makes obesity a risk.
Yeah. So maybe the things like hypertension, all that, all go along with the metabolic syndrome, but the real thing, maybe the obesity or the, as you said, the adipose tissue really is a major marker there, but maybe not just a marker, but an actual culprit in this. So that's kind of interesting. So thanks. So just that'd be a fun discussion to bring up. So Stein, let's see, did you find out anything in the interim? Am I catching you too early to talk about our first glimpse at what we're finding out about penetrating injuries across the United States?
Yeah, Paul, I took a glimpse into the survey, and it looks like a lot of people had opened it and got the information they needed about what we wanted, but did not come back with numbers. I do have some preliminaries though, but these are very rough. For instance, Denver has had a fairly significant increase from 2019 to 2020 as compared to 2018 to 2019. We're talking about, like in May, 140% jump as compared to a 65% jump the year before. In June, they had a 65% jump over the last year, where it was actually holding steady from the comparison from 19 to 18. In July, 75% jump from only a 1% jump the year before. Another significant one is the Detroit area, which isn't too much of a surprise. In August, they had a 35% jump as compared to only a 6% jump from 18 to 19. Interestingly, let's see, Hennepin had reported only a 9% jump from 2018 to 2019 and a 27% jump this last year in comparative months. Interesting, Albuquerque, New Mexico has had a decrease across the board.
Yeah.
And then also Oklahoma City, Tulsa also has shown a relative decrease. But not significant decrease. So we're still waiting for obviously very large cities to population centers to put in their data. And so we'll get more as we go along.
We already know from New York, from Kansas City, St. Louis, that they've already been reporting to us that it's going way up. Just wants to comment. Hey, so Jeff Goodlow, how do you respond to that? Is it just that the shooting rates are always so high in Oklahoma City that this is just a blip on the radar screen, right? No, but do you have any insight to that one, Jeff?
Yeah, I mean, I just think that it's a good example of that what we see in some cities, one size doesn't fit all. And I think that's part of the benefit of the diversity of our group, that not to dispute the numbers from anywhere else, but I think we have to be careful to always look at local data, because what is a dynamic in one place is not necessarily universal. And so we've got to be careful not to oversimplify or overextend any one locale's perception.
So we only have about 10 minutes left, and so I want to, if anybody just wants to, send me a quick note here that you want to talk, or you just want to pipe in now, let me know right now. But before, which I'm going to do is just go to AJ and see if there's anything to report from his end, and then of course want to go to Hillary if she's on still, and especially talk about what's coming up next week. Okay. And so anybody else want to pipe in or have anything to discuss today or report to me or us as a group? And if not, again, the invitation goes out to everyone to always please send me anything you want to talk about or give a presentation on for us, a brief one like we had over the last couple of weeks from people like Peter Antevi or Crawford and so on, or John today. So I always appreciate us having some input. All right, so with that, AJ, you want to tell us anything going on from your end?
Yeah, the big 56-page proceedings from the Paris resuscitation meeting will be going out today and tomorrow. And the very first article features Dr. Pepe, which is rather interesting, talking about meshing together all of the components of resuscitation. And it's a really great read. And we'll send it to you and you can redistribute it out to your personnel. Second, I want to give a shout out to Peter Antevi, because the national news really covered well, and you did a great job on it. It was on all the media, and I was really proud to see all that.
What was it on? I'm sorry, I didn't catch on what.
It was on testing. It was all of the various forms of testing, and Peter did a great job. There was a lot of good visuals of his system, and they gave a good coverage.
Okay, good. And Hillary
and my mom was happy. My mom was happy too.
Your mom
was, yeah, good.
Of course she was. That's right. And
Thank you, AJ. Appreciate it.
Of course, your wife was rolling her eyes.
And I do want to point out the supplement, the proceedings is a generic neutral from Take Heart America. It's not from GEMS. So it'll be being blasted out by EMS One and Hillary's group at EMS World as well. It's in advance of the meeting next week. It'll be great.
Yeah, I guess, Hillary, are you on? Looks like she got off. I'm sorry we missed her. So that would be too bad if that's the case. But I actually want to learn about how it all works and how you plug in. And, you know, in terms of if you're trying to attend the virtual meeting, when does it start? And, you know, where do you get the schedules and all that stuff is something I need to learn about. And that's what I wanted to maybe have her do. So, but anyways, just so you know, I guess the future resuscitation meeting, that's going to be, I guess, piped in through that starts, I think, on Monday and Tuesday, and then the rest of the week there are various other elements to that meeting. So I'm sorry I can't. Anybody have any information about that that you can relate to us since Hillary's not here? Okay, well, it'll be interesting because it'll be my first virtual meeting then, and at the same time I'm attending one in Brussels at the same time as well, virtually as well. So we'll see how it goes. All right, so I think that's basically it. Hey, Rob, Rob Holman, I was wondering, do you have anything to report from your end by any chance from Washington D.C.? We haven't talked to you for a while.
No, we're holding our own here, and we have been really good about doing our contact tracing for the people that have been exposed to the case, and also people who have been exposed to those. We have something like 92% of secondary contacts contacted within 2 days.
Okay.
And then we're going to be surveying 100 members, EMS members, every 2 weeks just to participate in a large screening that we're doing with the police and nursing home residents, et cetera.
Okay, got it. And then, hey, let's see, let me run over just quickly. Remley Crow, anything else to add in? I know I'm catching you off guard here a little bit, and your people have already pretty much covered a lot of things, but anything going on from your end? Sorry about that. There are people calling me with whatever. Go ahead. What is your emergency? Go ahead, Remley.
Nothing else to report beyond what we're saying about the NAMSP abstracts, looking at the comparison between sedation agents and then the overall epi of ketamine use in the pre-hospital setting.
Okay, and then you and I have to talk like later today, maybe about 3 hours. I sent your revision, by the way, and I think it looks great and ready to go. But we got to talk about the other one. I got to get you the data, so I've requested the Excel sheets. Okay.
Perfect.
All righty, everybody.
Paul, I think Hillary Gates is on. I see Hillary.
Okay, got it. Hey, Hillary.
I'm here.
Oh, good. Yeah, we were calling for you before. Hey, just can you give us a quick update because your show is starting on Monday. And so what does one do? Do we have to have pre-registered? Do we have to, what's the mechanism? Do you just sort of get on your computer all day or how does it work?
Oh, no, it costs about $4,000 to join, and you need that as a personal check.
Is that in oh yeah, so I was saying you take personal checks. That's right.
Yeah.
Okay, you did, yeah.
No, so Paul, you can register up until that moment or even during the week because all of the sessions are going to be available on demand for 365 days. So you can pretty much watch every single session at Expo for the first time ever instead of trying to split yourself into 15 different rooms in a live event. But we have Keith Lurie and Paul Pepe's State of the Future Resuscitation Conference on Monday and Tuesday, along with other pre-conference workshops. And then the main conference is Wednesday, Thursday, Friday from 9 to 5. But there's it's not all day, every day, just sessions. We have places to network and do fun stuff and visit the exhibit hall and things like that. So totally up to you how much time you spend on the actual Zoom.
So essentially what you do is you go and register for the meeting on your website, emsworld.com, and then, you know, look to the expo, then go to register. And then after that, it tells you what to do and how to do it, right? So.
You got it. And we have CME and nursing credits and CAPSI credits and everything. So trying to get the biggest EMS community we can, for sure.
Yeah, good. And then I can now go out and publicly speak about the TXA because the paper is out as of today. If you
Yeah. Did it get published? Marty said he thought it was today.
It just came in. And Deborah Prina just sent me a copy of it, so I'll send it to Jim and he can send it out to everybody else. So, all right. Okay. All right, it's finally out, so we can start talking about it. I love it. So, okay, good. And then I'm going to bring on the people from TCCC, I think, next week and try to tell them how they're going full court press to 2 grams for everything. So it'll be kind of nice to get their perspective because they're already doing it. Okay. All right. Well, listen, I think that's probably enough. We're at 11:58 my time, 12:58 in the East. And there's other things going on. Anybody else want to say anything before I get off? I don't mean to, you know, not calling everybody today, but we were busy. So anything else? Okay.
Thanks, Paul. Appreciate it.
Okay, got it. Okay, thanks very much, everyone. We'll see you later. Thanks for all your good work. We'll see you later. Take care.
Thanks, Paul.
Thank you.
Welcome back, my friends, of the show that never ends. Okay.
Thanks, Paul. Anything else you need?
No, thank you. We're cool from your end, right? So.
Yep, always. No
all right.
worries here. So sounds great. We'll sign off.
You. Yeah, thank you for everything. I'll see you later. Bye-bye.
Always a pleasure. Take care. Bye-bye. Do we need to do anything with recording before I end?